Okay, we're going to start the conference. And can everyone hear me? Is it Tricia or Sandra?
Yep, we can hear you.
Perfect. Okay. I want to introduce Kaylee Maynard. She's a second-year critical care pharmacy resident who is going to be presenting our first case involving buprenorphine microinduction. So here you go, Kaylee.
Okay. Hi, everyone. Thank you for having me on. Okay, so first we're going to get started. Our patient is CL. She's a 29-year-old female who presented at 37 weeks pregnant to an outside hospital with possible contractions, and she was also experiencing shortness of breath with fevers. Her past medical history was significant for opioid use disorder. Home med, she was stable on buprenorphine naloxone, Suboxone 8 milligram film 3 times daily. She also takes prenatal vitamins. Upon arrival, they did diagnose her with bilateral pneumonia. She was initiated on vancomycin and meropenem. She was also influenza A positive and started Tamiflu as well. The next day, they performed a cesarean section. After the cesarean section, she experienced respiratory decompensation and required intubation and PACU. Shortly after intubation, she just had worsening oxygenation. She developed ARDS as well as a postpartum cardiomyopathy. She was initiated on VA ECMO at the outside facility and then transferred to a tertiary care center for further management of her VA ECMO. Upon arrival to the tertiary care center, some significant events that were discovered. Her left ventricular ejection fraction was 20 to 29% with left wall hypokinesis. The team is describing her as persistently agitated. She was having significant ventilator dysynchrony and difficulties with oxygenation. Of note, her buprenorphine was held on admission both at the outside hospital and here transferred to the tertiary care center as well. The toxicology consult came to us late in hospital day 2, and this is what we were looking at when we went to evaluate the patient. She was on a fentanyl drip at 300 micrograms per hour. She was on midazolam at 10 milligrams per hour. She was on an epinephrine drip, and as well as milrinone for her cardiomyopathy. She was experiencing persistent ventilator dysynchrony and was very agitated. So looking at this, I think that would be a good point for a pause and just to see what everybody would recommend and what we're thinking of when we look at this patient.
And I just want to give a little context. The specific consultation was to provide recommendations related to the buprenorphine and to comment on the ICU sedation. We tend to get consults for some of the complex sedation, weans, as well as, when there's polypharmacy or multiple agents used and still challenges with agitation or, weaning. So any comments or thoughts? Let's see, just raise your hand. Or questions? So I don't see any hands raised. We'll continue for just a little bit, provide more of the case, and then we can, have some discussion. You can also send a chat if you don't have the audio. So we can continue right now.
What we had recommended when we initially evaluated her was to add ketamine in that day. So we came back on day 3. This is after our addition of ketamine and reassessed her. Her fentanyl requirements were slightly decreased. She was stable on ketamine, and her midazolam requirements were also decreased. She was still having reports of breakthrough agitation. The sedation scores that they were recording were a little bit lower. However, there was inconsistent documentation. So this isn't always reflective of how she was actually, if she was actually appropriately sedated throughout this entire time. We assessed her on day 4, and at this point, we wanted them to start to wean the opioids so that we could get her back on her home buprenorphine. We thought that this would be a good transition for her. They did attempt to wean the opioids. Her fentanyl was decreased to about 150, but she did not tolerate it. She was still having persistent agitation and ventilator dysynchrony. We recommended increasing her ketamine infusion, which in this patient population, there was a little bit of concern because she did have that postpartum cardiomyopathy. However, that did rapidly improve, and her left ventricular ejection fraction actually significantly increased. In a catecholamine-depleted patient, ketamine can act as a negative inotrope, but we did not see any of that in this patient. Her midazolam was also increased to allow us to try and titrate down her fentanyl drip. And again, this is unsuccessful. On day 5, realizing that we were going to be unable to get her off of her fentanyl infusion, we did recommend to consider a buprenorphine microinduction. And this was loosely based upon the Bernice method, which I know you're familiar with. However, the team had some concerns about that, and they decided to go ahead with what they currently had in this patient. And yeah.
I just want to take a break and talk a little bit about patients coming into the hospital on buprenorphine or when it's held, and you just get some comments and perspectives about what the different scenarios where it may be held, or preferences on continuing buprenorphine. I think as many of you have heard, my preference is often to keep the buprenorphine in place for almost all situations. But what are others' experiences and any comments or questions? Yeah, I know Henry Swoboda, you're on. Do you have any comments, or have you been involved with patients like this? Any suggestions?
Yeah, I mean, I've got a couple other members of the team with me today. I agree that we tend to keep our folks on the buprenorphine if possible. Sometimes we've tried to keep them on a somewhat lower dose and try some high dose opioids on top of it, high dose full agonists. Unfortunately, the case that we most recently had, we didn't have much success with that. We couldn't get the ICU team or the pain team to actually go up on the hydromorphone to a reasonable level, and we just found we had better success by splitting the Suboxone and adding on some IV buprenorphine and that sort of thing, and controlling this patient's pain after a laminectomy than we had when we were actually giving full agonists. So yeah, we tend to have better success that way as well.
We've got Dr. Naka here, colleague. Maybe you have some comments. You're involved in this case.
Yeah, it's nice to see it laid out like this, because I feel like I came in at a point where the patient was on really high doses of full agonist and midazolam and ketamine, and she was still at times agitated. And my theory was, at least in part, that she was having some delirium associated with the high-dose benzodiazepine. And so the idea behind the phenobarb load was to see if we could wean off the benzo. I was concerned that was the thing that was kind of making her the most agitated. But I think the case gets much more interesting after that.
Yeah, that's a good thought. I mean, benzodiazepine delirium is pretty common, and this patient's been in the ICU and on ECMO, and there's also polypharmacy. So, I think certainly a component. Does anyone have other comments or questions? We can, otherwise move on. Joanne, I see that you're on. Do you have audio? Dr. Lace? Okay, we'll move on. Go ahead, Stephen.
Okay. Yeah, we were re-engaged on day 9, which we've kind of alluded to the. Oh, hold on.
We're gonna.
Okay. I apologize. We were engaged on day 9, and as we were discussing earlier, she got the phenobarb load. I'd also like to mention, as far as her pharmacokinetics, on the echo, some of these medications were probably sequestered in the ECMO circuit, so that's probably some of the reasons for the high doses, as well as her volume of distribution was probably increased due to a recent pregnancy, and after her cardiomyopathy, she probably was not able to clear all of that extra fluid as well, so that's something important to mention. So as far as her sedation management, on day 12, we did have dexmedetomidine started. We reloaded with an additional 10 milligrams per kilo of phenobarb. She did seem to have a very positive response to the phenobarb. Every time that we loaded it, she was less agitated, had very little hypotension, because that was something that we were concerned about, and the effect did seem to persist throughout the day. We were able to taper down the midazolam after she received the phenobarb. Adding the dexmedetomidine allowed us to further taper down the midazolam. She was also initiated on quetiapine as well. On day 14, her ketamine was starting to be weaned at that point. She was down to 1.7 milligram per kilo per hour. Dexmedetomidine was titrated up to 1.5. We were able to discontinue her midazolam infusion, and she continued on quetiapine. On day 17, we were able to discontinue her ketamine. Her dexmedetomidine was at 0.9, and we were starting to taper down her quetiapine as well. So she was on 150 milligrams twice daily. Around day 10, we decided to start a buprenorphine microinduction because it was apparent that we probably would not be able to safely titrate this patient off of her full agonist opioids. And this is the microinduction schedule that we did use for her. This occurred over a 5-day period. Each time we went in to assess her, she seemed to be tolerating it well. Actually, it was really what stood out to me the most. She was very delirious on day 9 when we saw her, not responding to commands, not really responsive to her name or voice, not really able to track anybody in the room. And I know on the second day after we had started this microinduction, as well as decreasing her sedative requirements, decreasing the midazolam, we said her name, and she looked right at us and opened her eyes and was very redirectable at this point and started to seem to have this fog be lifted off of her, which I thought stood out to me the most. I think it was multifactorial, but it's just something important to note. I don't know if you have any additional comments.
You know, I think this is being done in tandem with the other adjustments on the prior slide. The only difference between this and the previous microinduction is the first dose we had done previously was with an IV formulation of 30 micrograms Q6 hours. We used that in the past because we didn't have access to the sub-milligram buprenorphine films, which we were able to get in time to do this entire microinduction. So, and this is started while the patient was on 10 milligrams of hydromorphone continuously per hour, along with all of the other sedatives. So she had the buprenorphine 75, 150, 450, and all of this is done with the hydromorphone in place.
Okay. I put this slide in here just to kind of show you the before and after. So this was before we really started to aggressively titrate down her sedative and started this microinduction. So as you can see, her hydromorphone was at 10 milligrams per hour. Her ketamine, I'm going to die. I'm so sorry. I'm so sorry. I drained my tea. It's fine. And then we started this microinduction. She was agitated, delirious, unable to follow commands. And at the end of the microinduction, and after we finished tapering off all of her sedatives except for the dexmedetomidine, she was awake, alert, her delirium was improving, she was following commands, and actually denying any pain. She was continued on Suboxone, 2 milligrams every 6 hours, and she didn't want to increase anymore. She thought that that was appropriate for her. She was able to verbalize that to us. And throughout this entire time, she's been continued on ECMO and pressure supporting on the vent as well.
So take time for some comments or thoughts. The reason we had done the microinduction was because we couldn't wean the opioids. Typically, we've been involved in a lot of ICU patients that come in are either opioid dependent, previously on buprenorphine, and when we're involved, it's typically we're having trouble weaning this patient. They get more agitated, and we're just adding agents on. And almost every case, it's been a recommendation. So we'll get them back on the buprenorphine, turn off the fentanyl, usually go higher on adjunctive agents, whether it's dexmedetomidine or benzodiazepine. We usually wait about 8 hours and are able to sneak in a small dose of buccal buprenorphine, sublingual buprenorphine. We presented this at the previous ACMT meeting, and it usually works well, but this patient wasn't tolerating any of the first fentanyl wean, and then they switched to hydromorphone either, and so it was a situation where we weren't able to wean the opioids, and so it decided to do this microinduction. Any comments or thoughts? We've got Henry. You still have your hand up. Do you have a
Yeah, I was
comment?
just, I had two questions. One was, what was her previous dose of Suboxone? And I just was hoping you could clarify the formulation of buprenorphine that you're using for the microinduction. Are you getting the like Belbuca, like small strips, or what is it that you're using?
That's a great question. Her home dose was Suboxone 8 milligrams 3 times daily. And what we were able to order in the Belbuca to have those small doses. We also have the IV form available.
The end dose that she stabilized on after the microinduction was 2 of the 2s, Q6. So she was on 16 milligrams of buprenorphine instead of just the 2, but that was just another increment, and then off of all of the adjunctive agents except for some of the neuroleptics. Kaylee, maybe you can comment a little bit about the removal of drugs during ECMO. In particular, we had to increase the dosing of phenobarbital quite dramatically.
Yes. So lipophilic drugs, especially, and those that are highly protein bound, are more likely to be removed in the ECMO circuit. Phenobarb, there's very little evidence. We were able to find one study of pediatric patients on ECMO that were requiring phenobarbital for anti-epileptic properties, and we showed there that a lot of higher doses were required to achieve adequate levels. So while there's really no level that we can guide us in as far as her sedation management, like we can get a level, but what does that really mean as far as her overall sedation and agitation? We kind of use that to guide us in the terms of, is it safe to give her more? So we only had to give her phenobarb 10 milligrams per kilo twice. We could have probably safely done it a third time if she had required it, but she had such a positive effect to that. Additionally, buprenorphine is lipophilic. It's not highly plasma protein bound, but we're really unsure what the ECMO circuit does to the buprenorphine. So that remains a question in our mind as well.
The phenobarbital was used earlier before the microinduction, really, or right at the start to help with the midazolam wean. It wasn't continued throughout or in the later parts of the course. Dr. Eisner, Derek, you have a question, comment?
Yeah, Tim. Hey, I guess my question is, in retrospect, would you have started the DEX sooner, and how much of the improvement do you think is coming from the DEX versus the microinduction?
We wanted to start the DEX earlier. She had tried it and failed. She became pretty hemodynamically unstable with dexmedetomidine earlier in her admission, but as she's continued to improve, this is something that we did recommend later on and had positive effect to it. Had she tolerated it earlier, I think that we could have added it on much earlier.
Right. Your comment and question, I think, get to, a good point. There's delirium potentially from the other drugs, and is it just simply removal and simplification of the other sedation, or, does buprenorphine have some particular mood stabilizing effects and, stabilization beyond, obviously the full agonists? And, I think that it's a little bit of both, but I've been particularly impressed, not just in ICU patients, but in, at all levels. Once we get somebody back on, their buprenorphine, there's often not just the withdrawal attenuated, but they have a mood stabilization effect that really helps simplify things. Nick, do you want to comment? I know that you had some thoughts on the benzodiazepine.
Yeah, I had reservations just with, she was so tenuous as from a cardiovascular standpoint, being on VV and VA ECMO, and also she was on pressors early on. I'm not sure that we were able to, and there was a lot of meds, so I'm not sure we were able to tell you all that she was on, but she was on some pressors as well. And so I had some reservations with the dexmedetomidine. And so we were trying to go with sedatives that had the least hemodynamic compromise. As we mentioned when we started the phenobarb, there was a discussion there as to, I was surprised that the team was willing to try the 10 milligram per kilogram loading dose, and I was delighted that there wasn't a lot of hemodynamic compromise. But yeah, I could see any other team being like, no, we're not going to give her 10 milligrams per kilogram of phenobarb, it's too sick. So I think that may have played into when we were able to get her on DEX too.
I see, Joanne, you've got, it looks like audio now. Do you want to comment on this case or any questions?
I think that it is really useful. We haven't quite gotten to that point where we've been able to do that, but we've had several cases where it seems like it'd be pretty useful to try to do microinduction of buprenorphine. One patient we had similar that was very agitated and we couldn't be weaned off of a ventilator, and they were like, he needs to restart his buprenorphine, and I wanted to use IV buprenorphine, but they felt like it was going to be taking, like we were going to use up all the hospital IV buprenorphine stores, so they didn't want to go that route. So we just ended up doing a hydromorphone infusion, and he stayed intubated for several more days. They also were a little bit concerned about using sublingual buprenorphine in somebody that was agitated because they didn't want him to aspirate it past the tube.
Yeah, that's interesting. I mean, it's such a small strip film that just gets kind of plucked buccally, usually sublingually. It's really minimal. In fact, I think even after keeping it there for a period of time, the residue or saliva could be sucked out. You're still going to get, some absorption. But this is, after the first one that we had done and described last month, several of, the ICU providers were very, impressed at the stabilization that occurred in the patient. And like the next day, we got a request to do another, do this in another patient. And although the response was, well, this patient will be very easy just to give some other sedatives, hold for 8 to 10 hours, and we can do the standard induction. And so, I think we had to kind of steer them. This is, we don't need to do this in everybody. It's a certain population that you really can't wean the opioids. They've tried other agents adjunctively to support while you hold the opioid, and it's just very challenging. I know of a couple of other individuals that have done this type of maneuvers, but it's not too common yet. In the pain world, there is some use of buprenorphine on top of full agonist, and with good response. It's very interesting, I think, and going to be an evolving area. Any other questions or comments? Want to talk about the considerations or any other?
I think a lot of these have already been mentioned. Ideally and optimally, she probably could have continued on her home buprenorphine dose, or at least some sort of buprenorphine product, and we could have medicated over that, but sometimes there's a little bit of issues surrounding that. You do need the smaller amount of buprenorphine, either through intravenous buprenorphine or the films, the buca films. And again, I mentioned earlier, there is an unknown effect of the ECMO circuit on the pharmacokinetics of buprenorphine. I know one concern that I had in the back of my mind, we really don't know a lot about it. Are we going to eventually saturate our circuit and then all of a sudden have a lot of active buprenorphine before we didn't? That didn't seem to happen in her. We monitored pretty closely. So I think there just needs to be further study and research on that for sure. But it worked well in her. I think it was a whole constellation of a variety of different things that we did, and I'm very happy of this positive effect. That's all I have.
That's great. Thank you. Before we get on to the next case, any other comments? Dr. Naka, Dr. Bashevitz?
I was just curious. How she did. Is she discharged from the hospital yet? Or
she's still on ECMO. She's only on her buprenorphine right now. They got her off of Dex. We're trying to titrate down the quetiapine, but it looks like she's doing better. She's doing okay. So
okay.
That's good.
Yeah, we rounded on her this morning, and they're planning to take her off of the ECMO circuit tomorrow. And what other changes do we have with their management today? Nothing.
She's really been improving since the sedation simplification, and also kind of the just support through ARDS and getting trached and going through the ventilator support trials and weans. So, all right. Well, let's move on to case 2. If anybody has other questions or comments, certainly after the fact, you can email or respond. We can also see the questions via chat if you have some. So we're going to switch gears a little bit and talk about a different type of case. A 27-year-old male with extensive substance use was arrested. trying to rob a bank. And he was brought into the emergency department during the booking because he was shaky and twitching and appeared to be under the influence of something. He's known to our service from many past consultations while in the inpatient setting. And years ago, the first time I had met him was related to a very severe MDPV intoxication with severe sympathomimetic toxidrome lasting for days. He then had a 25I N-bomb intoxication where he double dosed, and I remember his quote during the admission, saw the reality of string theory. It all became clear. And this is in the midst of very florid hallucinations, tachycardia, dilated pupil. He had very dramatic symptoms from a double dose of N-bomb blotter. And he had an ingestion involving 5-aminoindane, which resulted in serotonin syndrome. He was kind of a connoisseur of designer drugs. He progressed, unfortunately, with relation to the synthetic designer drugs to standard heroin, cocaine, marijuana, was incarcerated several times, related to drug importation, distribution of methadone, I think, initially. After his release, his use of heroin and cocaine escalated, and he was in and out of various treatment programs, including the opiate treatment program on methadone or buprenorphine, usually for short periods of time, just really struggling. He didn't drink very often, did smoke cigarettes. When he's brought into the ED, he's confused, tangential, he's intermittently agitated, but he redirects and calms, can have some of a discussion, but he's a little bit paranoid. He's gotten a little bit of lorazepam. His heart rate was slightly elevated, but not markedly so, 100. His blood pressure is elevated. He's breathing fine. His saturation is fine. He's got mydriasis. He has a dry mouth. He's got an ulceration under his tongue and on his lips, sublingual, fairly large ulceration. He's got a regular heart rate, mild tachycardia. He's got pretty significant new blisters on his thumb and burns along his first and second digits. He's got a tremor and mild myoclonic spasms with a little bit of clonus. Doesn't have any rigidity in his legs. He has very slight increase in reflexes. He's got a leukocytosis and a mild drop in bicarb. He's got a slightly elevated creatinine, and his CK is 1200. So I'm wondering, what do people think in terms of what he's been using, ingesting, and then just any comments in general on his history of designer drug use, progression of substance use. He's a self-described psychonaut, and he's able to pontificate about blue like drug form, opiophile, Arrowwood, has read all of Shulgin's books, can name a variety of medicinal chemists, cite references related to synthesis and various studies for novel designer drugs. He's kind of a street pharmacologist, very bright. So any questions, comments, or thoughts on what he might have ingested or used prior to getting arrested, robbing a bank? Request to go back one slide. Somebody got his exam and some of his data up. How about someone we haven't heard from? I see Dr. Wax is on. Paul, if you're able to comment, you want to comment on this case if you're able to?
Can you hear me?
Yep, you're good.
Yeah, I'm actually at the airport. I think I'll take a pass right now, but maybe I'll come in a little bit later.
Okay. All right. What about Mike Hodgman? Do you have I see you're on. Do you have a comment or thoughts on the differential? Mike's not there. What about anyone from the Miami Poison Center?
There.
Certainly. I mean, he's got a long history of abusing all of these cathinones, and any of these cathinones could really look like this. The burns on his thumb and finger kind of suggest that he's smoking something, along the style of a joint and letting it, go all the way down to the nub and then burning his thumb and finger on it while he holds it to his lips, or certainly some kind of crack pipe can, you can get those kind of burns as well. But I think any of these MDPV, any of these cathinones or crack I've seen look like this as well.
Good. I think your comments are right on. Certainly some of the things that we considered. Does anybody have any other additional thoughts related to his presentation, or even want to comment on, his progression of substance use to, kind of where he's at? We've got Derek. You've raised your hand again. Go ahead.
He's certainly at risk for serotonin syndrome again. I guess the question is how much of this is stimulant toxicity versus possible anticholinergic? Would you risk trying something like, FISO? But otherwise it's going to be to try to treat him supportively with benzos. But if we look at, our criteria for serotonin syndrome, he's already got some of the lab findings that are suspicious. He's got the clonus. So that would kind of be my first and an overriding concern.
That's good. Thank you. And I don't have his temperature up here, but he was not febrile, and he was not overtly rigid. There was some sweat. He wasn't diaphoretic, but we could get some moisture. He was, I think, dehydrated, and so, hadn't been sweating profusely. Dr. Bashevitz, you want to comment a little bit about his choices of drugs, his history, progression, maybe?
Oh, the progression, yeah. So this is, so I'm the director of a methadone program, and this is certainly a pattern that we see among many, many people. They may have used other drugs or designer drugs in the past, but eventually, after years have passed, many of them do settle down into regular heroin, cocaine, alcohol, marijuana, the usual 4 top suspects there. And usually it's got to do with money. You can get more bang to the buck by going to heroin and cocaine. And also I think sometimes people want, shall we say, a more predictable outcome, maybe. Maybe they're getting a little tired of the drama. I don't know exactly, but that's my impression of it.
I was just going to ask if you could further define the ulcerations on the tongue and under the tongue. That's kind of interesting to me, because with a crack pipe, I would expect burns around the lips from how hot it's got to get, but it almost sounds like maybe there's something systemic going on causing ulcerations elsewhere.
Yeah, that's a great thought. It was about a centimeter, if not bigger, like an aphthous ulcer, whitish, both on the tongue as well as underneath on the palate. And I think your questions about other systemic toxicity are very valid, but he kind of told us he'd been doing something. So I was a little less concerned if, about is this a viral syndrome or something where he's now, getting lesions or drug reaction potentially for, getting the lesions, some reaction, drug fever or something. So I tried to put a picture up of this, but it wouldn't, if I can send that out as a tweet later on in reaction. It's de-identified, but I'll follow up so you can all see that it's very interesting. So, I think, his progression, I've also seen, this progression, he was experimenting with a lot and kind of settled on the traditional drugs. And the comment about less drama is really interesting. I like the way that you put that. I think that at some level, maybe he certainly liked the drama and the interesting aspects, but a lot of the outcomes were ending him up in the emergency department, tied down, ending up on psychiatric units, and certainly had a lot of drama. So,
I think another point along these lines of why people progress to heroin and cocaine is many of them don't ever come to us when they're using all these bath salts and designer drugs, because they think they're perfectly okay and just using these things recreationally. And so we don't get a lot in a standard chemical dependency program. We don't get a lot of people asking for help for those. They're in the minority.
So his urine screen returned positive for amphetamines, cocaine, and opiates, and he had admitted to a crack binge, which the comments from Miami about blisters on his finger and from the crack binge, that's exactly what that was from. And he said he also was sucking a Wellbutrin because it tastes like Coke, and he described it as he knows it's a cathinone and it works just like cocaine. He was sucking on it for the taste and to keep the effects prolonged. He said he reported having 12 of them since the night prior, just kind of sucking on one, replacing it, and he's had abuse of bupropion in the past, both intranasally as well as taking it several times, or cheeking it and then taking more than the daily dose while in an inpatient setting and in other settings. He also was given a nicotine patch. I didn't comment on this, and had taken it off, and the police had missed this, as did the other medical staff. But he had put it on his gums and was kind of chewing the nicotine patch in order to get more of the nicotine effect. We removed that when we saw him. So I want to talk a little bit about bupropion abuse, but before we get into kind of some comments and points from the literature, does anybody have any experience with bupropion abuse? I know a number of you have seen it in the past. Anybody first on the webinar, and then I've got a couple people in the room that can maybe comment. What about the Oregon Center? Has anybody in Oregon seen bupropion abuse?
Oh, there you go. Yeah, we've seen a lot of people on it, teenagers and preteens who overdose on it when they get depressed. Do some of them intermittently abuse it as well and snort it or crush it? Probably. We haven't delved into every which way they use it, but yeah, we've sort of written a big word of caution of not using, a 90-day supply in a teenager who may be prone to overdose. But as far as the people who crush it and snort it, no, I haven't seen that much of that.
Yeah, those are good comments. Go ahead.
No, I didn't say it. That's it.
Okay. I think the comment about not using a 90-day supply and somebody at risk is, very valid. One of the first cases I consulted on in Rochester was a 20-year-old who took a 90-day supply intentionally shortly after starting it and ended up being a fatal overdose. This was, I can still vividly recall, that case. But I've seen a number of individuals abusing it, and it seems either often the inpatient setting, the chemical dependency programs, halfway houses, people that are monitored, and it's becoming a bigger deal prescribing to kind of at-risk populations because it's known. It's got I've heard it referred to as poor man's cocaine. Dr. Bishevitz, you want to comment? I know you've seen this before.
Yeah, so part of the work I do is at an inpatient rehab, and I'm a psychiatrist. I do psychiatric consultations there. We psychiatrists really like Wellbutrin because it's a very useful psychiatric drug with a totally different side effect profile from the standard SSRIs and SNRIs. So we don't want to get rid of it exactly, but at this inpatient rehab, there has been a spate of people trying to cheek it and then sell it or give it to others or trade it. And then the people are snorting it, crushing it and snorting it, and so forth. So one solution that I've heard about in jail at least is to change all the sustained release Wellbutrin forms into immediate release forms, and then to do something called crush and float, which is the staff crushes it up and floats the immediate release form in some water or maybe some applesauce, and then the patient ingests that. So some facilities are going to that. This particular one I work at has not gone to that yet, but we've certainly had a lot of people abusing Wellbutrin. Yeah. Oh,
That's interesting to hear. My experience before I worked in Rochester was in Vermont, and I saw a lot more bupropion abuse there. In particular, I saw a lot of people injecting their bupropion, and I saw a lot of vasculitis, pulmonary embolism, some arterial vasospasm associated with injection. And I feel like maybe it's a regional thing because I really haven't seen it, or maybe I'm not getting consulted here, but I haven't seen it to quite that degree. I haven't seen anybody injecting their bupropion since I moved here. But yeah, that's interesting. I've heard of it. I can't recall consulting on injection, but definitely individuals insufflating, or sniffing it, taking more than is prescribed, and this is the first sublingual absorption and abuse that I've heard of. So, any other? UC Davis?
Yeah, we were just comment. I think a lot of previous commenters said the same thing. We published a paper about 10-year review of the California Poison Control Center data about bupropion. There was about 40 or 50 people who abused it, meaning they insufflated it, they crushed up and stored it. A lot of them are prisoners, and turns out that seizures are pretty common, as is like agitation. And I think in that review there's only one or two that intravenously inject it, so pretty common.
Yeah, that's great. Thank you. So I've got a couple of references related to bupropion abuse this past year. There was a systematic review of the preclinical, clinical, and post-marketing evidence for misuse that looked at the pharmacology and some of the reinforcement studies, and I've just got a couple of quotes as well as the reference. They determined there was some potential for misuse, but it is different from other structurally related stimulants. It is a cathinone, beta-ketoamphetamine, limit the reinforcing effects, and one of the comments in the conclusion section, preclinical evidence demonstrates some potential for misuse based on psychomotor discrimination, self-administration, and condition-place preference tests. So different models of reinforcement, it certainly tests positive with, and they qualify that with the potential is less than that of commonly misused stimulants in real-world setting. Misuse of bupropion occurs, but is uncommon. I think actually in certain populations it is more common, as people have suggested in regional variations, and they suggested that adverse effects of bupropion misuse are frequently cited as significant barriers. So the seizures, the serotonin syndrome. People don't like the twitching, but it is a substance of opportunity. If it's around and nothing else is there, I've seen definitely people seem to tolerate the potential adverse effects. There may be individuals that are at higher risk for its misuse, like people that understand the pharmacology, that it's a beta-ketoamphetamine, halfway houses, monitored programs that don't have access to other substances, and I've seen references, just case reports about treating cathinone dependence with bupropion, so using this as a beta-ketoamphetamine to treat cathinone dependence. There's some literature historically about its use for stimulant use disorder, methamphetamine and cocaine, and from what I understand, it wasn't very effective. Do you have any?
I don't have any other.
No, so if there's any evidence contrary to that, if somebody wants to comment, but I don't believe it's been effective. And again, special populations that may be at risk. There's a case report of severe recurrent abuse in a patient with longstanding bulimia nervosa and complex PTSD, and there's a thought that the eating disorder population may be at risk for abuse because of the anorectic effects and also the reinforcing effects. Do we have any other hands up? Paul, Dr. Wax, you have your hand up. Do you have a comment or question?
Yeah, thanks, Tim. Yeah, hi. Well, it's a fascinating case. I just have a question about the use of bupropion, in this case, to potentiate the cocaine effects. Is that well described as a potentiator, or is this more of a kind of a unusual case?
Yeah, that's good. I don't think he was necessarily using it to potentiate it. He was oddly described as, and also the timing wasn't exactly clear. I think he had this binge, and then he'd been taking it. It was my understanding that or interpretation that he ended the binge, needed money, and then he was trying to rob a bank. So this is in the midst of, had a cocaine binge and then was using the bupropion. He may have been while he was smoking, but I didn't clarify that. It wasn't my interpretation that it actually was used to potentiate the coke, but he got a cocaine-like effect as well as the cocaine-like taste from placing it sublingually and just letting it dissolve. So he was getting this taste and memory recall, I guess.
Yeah. Okay, interesting. Great, thanks.
So he was treated with benzodiazepines, hydrated. We got another CK, and he was actually improving. There was no seizures. He wanted to go back to jail and seemed to be headed in the right direction, and he was released in custody, and not sure what will happen with his bank robbery fiasco. Let me see if there's any other hands up, and otherwise we'll go to a third case. It's a little bit shorter. All right. Thank you all for those of you that commented. If there's any other questions, comments that you want to use the chat for, remember we have the chat option available as well, and I can read the questions or comments. So case 3 is a 26-year-old female, long history of substance dependence, addiction. She presents to an outpatient clinic for evaluation of pregnancy termination. She's 20 weeks. She admits to heavy heroin use, and she's also clonazepam and amphetamine dependent, on and off illicit use from prescribed. She'll have a prescriber for a period of time and then get caught with the urine screen where it's not in it and get taken off, buy them on the streets, and then get someone to prescribe again. She also is using gabapentin and intermittent cocaine. She's sent into the hospital for monitoring overnight instead of just coming in to the procedure because she has an abusive boyfriend. She had last used IV heroin 4 hours prior, and we were consulted to provide recommendations related to the withdrawal management and potentially the referral. She's interested in getting some help and follow-up, and she's terrified about precipitated withdrawal with buprenorphine, and she says, because I've been using a lot of the fentanyl, and she says I need to go days to not have it, meaning the precipitated withdrawal. She's got a friend with her, a male friend, who really reinforces her thoughts about this precipitated withdrawal and that she needs to go days, and she knows people that went 4 or 5 days and they still had precipitated withdrawal. So I'm wondering, first, what are the options for this patient? It's in the afternoon. She's going to get the procedure in the next morning. What would you do, or what's available to treat her potential opioid withdrawal, as well as maybe benzodiazepine withdrawal? We don't have any urine screens or data, and she is not in withdrawal, looks fine, is eating a chicken dinner. She has stigmata of IV drug use, but no signs of infection, normal vitals. She's not in withdrawal at all. Again, last heroin use 4 hours prior via IV route. What are our options for withdrawal? What about Ashley Webb? Are you able to comment? Rachel Whiteman? I think you have audio. Do you have thoughts or comments for her withdrawal? What about, all right, Joanne, Dr. Lace?
Don't really understand why people are saying that about fentanyl and having that experience. So I basically, if they're concerned about precipitated withdrawal, sometimes we give them the option of coming in to be observe during that when we're doing induction for them, or I do a much smaller dose of inducting medication for them.
Yeah, that's great comments. I think in our area, we've really had a lot of problem in detox, in whatever settings where people are getting inductions, that patients are concerned and report having to wait longer with the fentanyl. And it's not just fentanyl, it's potentially, whatever the fentanyl is in the street, which mostly in our area seems to just be regular fentanyl. But they describe having to wait and having episodes of precipitated withdrawal with which standard heroin in the past they didn't seem to have. And I've heard that. I've gotten emails from others around the country, reporting the same thing. Patients are reporting this, they need to wait longer. And my response is usually, well, in the hospital setting when we're using fentanyl, we can turn it off and wait 7-8 hours later and do a small dose and then go very quickly, and we don't have precipitated withdrawal. So I think I've mentioned this in the past. I have some thoughts about this, but does anybody else have first experience with this or comments? Henry?
Yeah. Hi. We were just discussing this very issue this morning during rounds, and we were thinking that, just as you said, that while pharmaceutical fentanyl that we use in the hospital, we're able to transfer people over, but a number of our patients are saying to us that their dealers are telling them that their drugs are cut with methadone, and yet their urine drug screens are showing up negative for methadone. And, we're wondering whether there's a long-acting synthetic opioid that we might not be picking up. And we've had that experience with some patients where, we've done a room search, we've done the whole 9 yards, and it takes them days to go into withdrawal. And then when it hits, it's bad. And I don't know, have we seen someone go into precipitated withdrawal after too long? Really, not exactly,
but I'm not sure.
Yeah, it's not exactly that clear, but it's because we've been waiting. We wait for them to go into withdrawal, and they don't have opioids for a couple of days, but then they go into real opioid withdrawal, again, with no methadone and picked up on the UDS, and people are telling us this exact story. So we've been tending to believe them and just wait until they say they're ready. In the past with our heroin patients who are really heroin, I say, well, if it's been 24 hours, they're going to be okay. Even if they have a little bit of a withdrawal, I just kind of move ahead with a little bit lower dose. But usually we've been waiting a little bit more, maybe treating their symptoms a little more with clonidine and maybe some olanzapine to help with nausea, as well as sedation and all those other adjuncts for a little while until they're like, no, I'm actually ready now. To start on a Suboxone. I don't know if you guys.
Yeah, I think that the patients are saying fentanyl or methadone because those are the words they know. But I think there's a chance that those are blanket terms for all number of synthetic opioids that could be getting mixed in on the street that have maybe half-lives that we have no idea. Because we are seeing patients take much longer to go into withdrawal here in Chicago. So
yeah, and then it's interesting. Great comments. Been skeptical, but I've seen it in a couple of cases as well. But I've also seen kind of some drama where I didn't think that it was precipitated withdrawal, just, younger users that seem to like the drama. Recently, I had done an naltrexone induction after a patient we planned on doing a low-dose buprenorphine induction to get him out of withdrawal, like one day, and then 2 days later, start a very small dose of naltrexone in the evening, the next day bigger. So doing this kind of titration up on naltrexone to get onto Vivitrol. But he never went into withdrawal. So day 4, we just moved ahead, and he was feeling good. I thought this is going to be a piece of cake, but the first 2 nights were really rough. So I think I've also seen this happen, and people are insufflating the heroin, and I think that they've got a little bit of a depot. So I'm telling my patients, it's like a fentanyl patch. If you are sniffing it and you got you're congested, and you got a bunch of heroin, go and make sure you rinse out your nose really well. And then I think some of the IV users, if they've got really poor veins, injection, and have been heavy use, especially before coming into a detox or before their induction, they may have some subcutaneous kind of burden of fentanyl potentially. I don't see in our area crime lab in the reports, and I've gotten some of the reports, we have some designer opioids, but there's mostly fentanyl and some other, and it doesn't seem that there's unique opioids that are responsible for longer. That may be in some of the case, but I don't, believe it's all the case. So it's an interesting world with the change, it's not reliably, this is heroin, here's how to do the induction, which has implications for, protocols. We're doing more emergency department induction. If you want a simple cows above this, do the induction. If patients come in and say, well, I have to wait 2 days, that's going to really mess things up. So, yeah, I don't know. This patient wanted to get an opiate treatment program for methadone maintenance in the past. She's been denied due to benzodiazepine misuse and some other issues. There's currently a 40-plus patient wait list at one and a longer one at the other opiate treatment program in town. We could have just simply used some methadone, 30 milligrams if she goes into withdrawal overnight instead of buprenorphine, but that wouldn't have been a fix at the end. And so we really kind of tried to calm her and reassure and say, well, we'll watch, do adjunctive medications, just as Dr. Swoboda had suggested, and get her onto buprenorphine if we can. And she had a comment that I thought was interesting. I've not seen this work, but I wanted to ask Dr. Bashevich, she's our opiate treatment program medical director. This patient knew a friend at a different satellite OTP who gets rides to this program, was able to get into this OTP and was waiting until the slot they opened up, their number came up in the more local methadone program, the OTP, so they could transfer. And I'm wondering if you have any experience if, your local opiate treatment programs are full, if, regionally someone's able to get access at one and then switch very easily. Is that a common phenomena?
Oh, sure. So we do that all the time. And when you're a methadone patient, you are entered into a database so that people can't participate in two or more methadone programs at once. And people do certainly do this. We've even had people going, when Rochester programs are full, sometimes we have people going all the way to Syracuse for their methadone. That's a distance of about, over 100 miles, and vice versa. And then later on, they stay on the waiting list and they're transferred later on. So yeah, that's just the nature of opioid treatment programs using methadone.
Do people typically, are they able to arrange transportation for something like this, or are they pretty much then, if you can get there, we'll be able to set this up?
Well, I think all of the above. Sometimes counties will approve Medicaid transportation to another opioid program out of town. And that's a lengthy cab ride sometimes, so it boggles the mind, but yes, all of these things happen.
So trying to stick within an hour, I'm going to finish this case up. Dr. Swoboda had commented on, adjunctive medications. We recommended clonidine. Our typical protocol is 0.1, 1 to 2 Q6 PRN with hydroxyzine, 50 milligrams, 1 to 2 Q6 as needed. If somebody needs other things like melatonin, that's fine. In an inpatient setting, if they're in an ICU, if there's pain involved, and we're really trying to do a short induction, I'll sometimes use a dose of diazepam overnight if you're really trying to do a quick, less time in between, and there's a risk for patient maybe leaving. That's the benzo's the carrot on the stick. And because they were so worried about the precipitated withdrawal, I said, well, we'll do a low dose. We'll do half of a 2 potentially as the first dose, and then rapidly titrate up as long as you're in withdrawal. If you're not in withdrawal, then we won't need to treat you overnight. We'll make sure to, treat you and keep you comfortable. And then look into this, question about getting bridged to another method, the opiate treatment program. She didn't require any buprenorphine, didn't get any overnights, and then the next morning was gone, so didn't stay to get the referral or follow-up, but didn't end up getting the buprenorphine and had the procedure from what I can understand. But, we'd left some recommendations. So it is 2:15. I have one other case that I think I can save for next time on in an outpatient clinic. If anyone has any other questions, comments, please, we can stick around for another minute or two, but otherwise, please join us for the third Friday in March. And again, if anyone has cases, it'd be great to get your cases as well to present. Just email me. This will be posted online on the ACMT website if you have any colleagues that are interested in reviewing. Any other last questions, comments on this? Henry, is your hand still up from before, or you have a parting comment?
Yeah, Jenna was telling me that she'd been on a webinar where you discussed the kind of methadone database before, but I feel like we're always, bending over backwards to verify somebody's methadone dose, and they come in on a Friday night, and then Monday's a holiday, and now they're supposed to be getting 200 instead they're getting 40 all weekend, and it's just like such a huge hassle, and obviously, it doesn't show up on the prescription monitoring plan. I just wonder, it's probably not in line with the current law, but there should be some way that inpatient addiction medicine providers can get access to the database so that we can actually verify doses and provide continuity of care. I don't know what your thoughts. What are your thoughts on that? Yeah.
Well, you are certainly preaching to the choir here. I think it's just awful that patients are admitted to the hospital and their treatment providers have no idea how much methadone they're on, and they can't possibly verify it because there's just a labyrinthine way to do that. So you're right, it's got to do with the confidentiality laws and the fact that they're not on the prescription monitoring program sites, and the reason for that is it's those confidentiality laws. So all I want to mention quickly is just the way we've solved it in our institution, and we've sort of solved it because not everybody knows that this is the answer. So what we do is we manage our methadone by a certain software program, addiction management system, which I think was taken over by some other company. So we have a license for that installed in the emergency department of the psychiatric emergency here, and the charge nurse in psychiatry knows how to access these through this software, and that is a very circuitous way to get at it, but at least we have a way here.
Yeah, and that's for our on-site program. The other one in town, we have contexts at the medical director level that really aren't ideal. It would be much better to have the access to software and a representative that could look into that. So.
Yeah, unfortunately for us, it's like there's just so many different methadone programs in the city of Chicago. We just can't have relationships with that many programs, and are stuck, in a pickle quite frequently.
Yeah, it's if I can't verify a dose, my practice is 30 and then another 10, and that, which is usually enough even at the higher doses to get them out of withdrawal, and then we'll use some supportive care and then kind of reassure that look, I'm looking into this and really trying to contact your program. And then if there's acute pain on top, then there's some flexibility. If it's just dependence and withdrawal, usually within 24 hours, even at remote programs, we're able to get some information, but it takes some time. It should be much easier. So we're a few minutes over. Thank you for joining, and again, third Friday in March, and have a great weekend, everyone.